logging on here. It's 3:02. Yeah, let's go ahead and get started. Again, my name is Kim Taylor. I'm chair of the advisory board. I have already kind of checked in with some of the folks that are here. Let me just very quickly again go through who I have and who I've missed because folks have been logging on. So again, myself and Shane are here. Gail is here, Jackie's here. Michael from the sheriff's office. Karina is here. I am seeing again Tom here, Chantel, Liz Perez, Tony Price, Kayleen, thank you for being here. Is there anybody else, Catarina County, Jessica, is there anybody else that Nancy, of course, is there anyone else that I'm missing that I did not call on?
Did you say Tom Ghost again in this?
I did, yeah.
Okay.
Tom again, yeah.
Yeah, and so Justin will be here shortly. So I think that's everyone that we have that's in attendance.
Perfect. Okay. So I've heard we have a quorum. So if you've not had a chance to take a look at the last meeting minutes, if you could take a couple of minutes to do so, that would be appreciated. And then once you've had an opportunity to review, if I could get a move to approve or comments on any changes or additions that need to be made. Or changes.
I motion to approve, Kim.
Okay. Thank you, Shane.
I'll second.
Oh, okay. I think I heard Gail first, but thank you. Okay. So let's go ahead and have that as approved and ready to go. Appreciate it. All right, on item 3 of the first part, let's move on to the board member updates. And it looks like, is Kenny here at this point?
I don't believe so.
I don't believe so. Okay. If Kenny should come, we'll go back, circle back around and have him introduce himself. So moving along, let's go to Katie. And I don't see Josh here, but he may come in. But Katie, I'll turn it over to you.
Thank you. And yeah, actually, Josh isn't here today, so I'm going to be the point of contact for this. Also, apologies in advance. My computer's being a little slow, so fingers crossed this is going to work without me having to restart. Yeah, so we're here today to present a high-level view of the Initiative for Student Wellness. We are awaiting the Board of County Commissioners, their review and approval of our final report for the 2024-2025 data. And so once that's reviewed, then we'll be able to release it and we'll send over copies to you right away because we're really excited about the results. So just kind of, just real broad, and we can get more into depth once we have that entire report to review. So hopefully we can get that scheduled for the next BHAB if possible. But I will say, this year we were able to serve 8 schools, which is exciting. And we had a goal of screening 1,000 students, and we were actually able to get 1,200. And 1,000 of those participated and completed the screener. Some of the interesting data to note is that we were able to provide 10% of 10% of our students some sort of referrals, whether that's community services of some kind or a higher level of care in terms of treatment. We found that our participation rates within the survey and our program, for those who completed the survey, we had students participating as good or better than the Healthy Youth Survey screening. And I think our sense is that's a testament to all of the schools and the students as we've moved. We're now moving into our 4th year of this program. And we have found that with each passing year, more kids are looking forward to taking the survey. Kids are requesting to meet with the clinicians they had previously met with. We have more interest in group participation. Even over the summer, we have some clinicians in the Spokane Public Schools who are serving these kids all year round. And it's just every year we just have more positive engagement. We have a lot of students who are referring friends of theirs to this program, to these clinicians, because they found that their support was so helpful. And so we're just really excited. And every year we're getting requests for more and more schools. And so well, we don't have any information on that right now, but we are hoping that will continue to expand, but we want to do it carefully and thoughtfully so we're not overextended. So, more to come on that. Something interesting in this past year is we had a school, Three Springs, which is sort of like an alternative school. So it's kids with like higher needs in terms of supportive education, behavioral health concerns, et cetera. And so, and we'll present this data later, but we did find those kids who are in the, we have 3 tiers. And so the tier 2 are sort of maybe needs that aren't quite as urgent as those who are the tier 3, tier 3 being like imminent risk of harm to self or others, tier 2 being more concerns such as drug use, maybe anxiety and depression, but aren't requiring that immediate by the end of the day kind of intervention. All clinicians try to get those tier 2 kids within 2 weeks. And we did find in part because the Three Springs School, which is in Cheney, it's a high school, because those kiddos are just, initially they were already requiring more services. They have more behavioral health concerns. That our numbers in terms of the 2 3s are quite a bit higher than of previous years, but that was to be expected. Additionally, we also have Riverside High School, which we've been serving for the past few years. That's up in Chattaroy. And we found that there was higher level of need, much more engagement. And of the kids who had participated in the program and had enrolled with a clinician, we actually had, due to our clinicians' capacity, only about half of the kids this past year were able to enroll in those services. But in spite of that, our clinician provided as many services, as many referrals, as many engagements, because these kids just required so much additional care. One of the interesting things up in this in region is apparently there was a drug dealer who had been known to be dealing to kids, including high school students in this school, that was sort of his target. He was arrested. And the clinician that we have there suspects that because these kids were suddenly withdrawing, that they needed more support. And so they were more likely to seek out a clinician, having a higher level of need, but also being more willing to engage. And so she was able to support them. She's our only SUDP provider. And so we're really happy that she has that experience and was able to support these kiddos in a way that is rare for a lot of our schools. I mean, we really wish we could have SUDPs in every single school. I mean, there's really such a need. So, again, like they're another contributing factor to us having those higher tier 2s and tier 3s. But we will present more on that later. We also found this past year that about 85% of the kids who had participated, this screening tool in the ISW program was the first time that they had any sort of connection to any kind of behavioral health services for a variety of reasons. Most kids have suggested that they would prefer having in-school services because of the convenience. For those kids who are 13 and older, they have that privacy that they can seek out behavioral health services without requiring the permission of a parent. And so they're able to get the help that they need without, requiring transportation to in-person services or having that be like before or after or during school. And particularly in our rural frontier areas, it's just really challenging to have that transportation to those services. So we're happy to provide support there. Gosh, I'm trying to think what else. We've been able to meet all of our targets in terms of supporting those tier 3s by the end of the day. We have had, particularly in this past year, you know, initially when we started this program, with every new school we're bringing on, sometimes there's a little reluctance or concern on behalf of the school staff, like, what is this going to look like for us? How much involvement is going to be required of us? How much is this going to take up in the school day? And now that they're familiar with the program, they're recommending it to other schools, and really like engaging more and realizing the benefits that ISW brings, and how it's, you know, we're getting anecdotal reports that, you know, we're not, like, of those kids who have gone through the program the following year, we're not seeing as many of like the high intensity needs that we have previously. And we're not seeing as many by the end of the year, we're not seeing as many like disciplinary actions or school absences, et cetera, that kids are just engaging more in the program, and they're having more successes, not just on a behavioral health side, but broadly in terms of all of those other, you know, external factors, those external measures of success. And, you know, as well as just being more engaged, increasing their sense of belonging with the schools. I mean, one of the schools that we have in Freeman has reported that 100% of the kids who participated in the program felt that, regardless of the concerns that they had, the level of need that they had, they all felt that they had somebody at the school, some adult who was able to provide support and believed in their success. So yeah, just like really exciting, and really like having ISW sort of foundational to kind of, you know, coordinate all of these, you know, the variety of services there, some of whom, in one of the schools we're in, when we had our like introductory meeting for like Initiative for Student Wellness, here's what we do. Two of the organizations that really their services dovetail so well, they didn't even know the other organization existed under that roof of that school. But because of ISW seeking out all of those resources and finding, you know, how each individual school can support their kids, they're able to bring other services together and make appropriate referrals. So yeah, we're just really excited, and really excited about what the next year is going to bring. So there's that little short and sweet intro.
That's
Does-
fantastic. Your numbers sound wonderful.
Yeah, it's been a really, really great year this past year. Yeah.
Yeah.
Any questions for now? Right. Maybe not. Hearing none, we'll be able, oh, Gail.
Of course, I have a question.
Yes. Love it.
Can I, is there a way that I could look at the survey tool? I'm just kind of curious how it looked, how many
Oh,
questions.
yeah.
Would be
Yeah,
awesome. And
definitely.
you could compare that or correlate that with these results as well.
Yeah. Happy to send that link over. Just to keep in mind, we have, through our software program, which is called Ticket Health, and it's the Check Your Health Screener, we have a basic demo, but some of the questions we have aren't asked of our students. We got feedback from the schools about what might be appropriate, what parents might have concerns about in terms of questions, and we really wanted to find something that was going to, you know, be acceptable and appreciated, and we weren't going to have concerns about some particular demographic questions. And I actually, while we're chatting in a second, and maybe when we move on to the next speaker, I can pull that up in just a second, and I'll put it in the chat. But the feedback we've gotten is like, the software is really cool and it looks good. And we hear from students like, it's like, this is something I would take on my own if there were an app, you know, it's just like, it's really user friendly. There are, you know, based on your needs, it'll provide feedback if you want more specifically about things like sleep hygiene, drug use, et cetera, with those options of, here's a little bit of information. Would you like to hear more? So you're really getting that buy-in rather than feeling like something is so prescriptive or cookie cutter, or that it's, you know, just really preaching to you, which can kind of turn kids off when it's like, yeah, I got it. So yeah, it's cool.
Okay, well, thanks. I look forward to it.
Cool.
Yeah.
Katie, does the demo include the education questions, the ongoing education questions?
No, we had an additional, we had some college and career questions, and I don't believe that was included in the demo. I'd have to go and double check. It's been a little bit since I've looked at that, but I think those are some of the questions that, because we had added it, they weren't incorporated into our demo unless they had changed something recently.
Yeah, so you will see a little bit of difference in the data that's put out for the final report that we're currently working on. Some of those questions may not be in the demo that she's going to share. So just wanted to make sure that was out there.
Thank you. I'm
Yeah,
looking forward to it. Sounds awesome.
yeah, it's cool. We're excited.
Yeah, we love it.
Thank you, Katie. Appreciate it.
Yeah, thanks, everybody.
Yeah. Okay, let's go ahead and move on. Actually, I want to welcome Dustin. I see that you've come in. Thank you for being here. Let's go ahead and go to administrative updates. Jessica?
Wonderful. I will be starting us off with some of our administrative updates. As many of you know, I'm a behavioral health supervisor here at the ASO and happy to be here with you all this afternoon. So first up on the list is to provide some crisis system updates, beginning with the endorsed mobile rapid response crisis teams. I believe at our last Behavioral Health Advisory Board meeting, we had discussed that our region only had one team apply for endorsement, and we are happy to share that Frontier Behavioral Health has received their official notification as of August 1st to be an endorsed mobile rapid response crisis team. And what that means is that they will be able to operate this specific mobile rapid response crisis team for Spokane County 24/7 and be able to respond to behavioral health emergencies within 1 hour. This also allows them to have 5 vehicles that can assist with transporting individuals to stabilization services as needed. So really excited to have this new team on board and to have another level of response. And this is specifically for Spokane County, as Frontier Behavioral Health is the crisis provider for Spokane County. Any questions on the endorsed teams before I move on to new facilities?
This is Mike from the Sheriff's Office. Just a quick question. Are they going to socialize that with law enforcement for those kind of crisis calls that might not need an officer but could use their services? Because this is the first I've heard of it.
So I'm not sure if I fully understand or am understanding your question, but yes, there are definitely, as you are well aware, situations in which Frontier Behavioral Health, their crisis responders can't go out on their own due to some safety concerns. So oftentimes law enforcement assists with those outreaches. And in those situations for this team as well, that does apply. So if there is a situation in which safety is a concern, we would still be requesting assistance from law enforcement on those calls.
I guess maybe I'll frame my question differently. Are they going to socialize that with law enforcement so we're aware of this new program?
Gotcha. Yes, I believe that they will, and if not, I will make note of that and make sure that we get
Jessica,
that connection made.
Yeah, that's already ongoing. Because we're going through Frontier Behavioral Health with the existing relationship, there's going to be a 2-part process for informing and coordinating with law enforcement. FBH will utilize the existing trainings that they do, not only for law enforcement, for the community, to provide background on what this team is and the expanse, what that expanse looks like in terms of providing care. We hope, and the goal is for a more rapid response and more comprehensive response. The second part is offline meetings with law enforcement, both the sheriff and city leadership, and then on down to direct staff to provide that information. So that is ongoing now. The teams haven't all been hired. There's going to be 20 new individuals. So once those are on board, that's when the onboarding with law enforcement will occur. And really, there needs to be some process worked out. So that's still forthcoming with law enforcement's leadership to say, when a call out goes, because now we'll have more of a rapid and comprehensive response, how will that look? And will it occur after, before, or during? All of that's going to come. And part of that's going to require law enforcement to provide some feedback as to what works best, right? If the sheriff's department's up in the Northeast region and they're doing a response out in a rural area, is the response there? Do they drive in or do they meet them somewhere else? Do they home visit? If it's more centralized in like the valley or some other easily accessible area within an urban center, all of those nuts and bolts need to still be worked out, but it will imagine the existing framework that's in place being enhanced and given more ability for coordination than currently is there. So it's just going to improve the tools that law enforcement have, as well as the call out ability just working out those little nuts and bolts are still forthcoming.
Thank you.
Thank you, Justin. Any other questions about the endorsed mobile rapid response crisis teams before we move on to our next item?
Yeah, this is Karina. So if we're out on the streets helping somebody, is it the crisis 988 number, or that's the number that we would be calling to get somebody connected with? What's the bridge?
Yes, you can call 988 directly and be transferred to a mobile crisis team so they can be dispatched.
Okay.
A little bit of clarity on that, Karina. If you are an individual in the community and you're encouraging community members experiencing behavioral health crisis, you can access it through 90-day. If you are a community provider who is making a referral, or law enforcement making a direct referral into our MDU unit, we have an MDU line directly. Now, that is not meant for community members, because the goal there is for them to receive a behavioral health service where they can have the immediate crisis resolved or immediately addressed on the phone and then referred for a dispatch. So there'll be two kind of processes here. The line that the community utilizes will only be for those that have a direct referral process. So for your purposes, if you're a provider on the street and you're seeing somebody, you may have already called 911 to get a response out. Law enforcement may have already called or will call FPH, Crisis Response Team. But if you are making a referral and the individual is being transported up to the hospital, then you can call that line directly and say, hey, this individual is going out to the hospital, or there needs to be medical clearance. That will allow for an immediate dispatch without having to go through the entire 90-day system into, a behavioral health clearance and then into the MDU. So it's a little bit of a clearer pathway. Law enforcement, of course, will have priority on that to ensure that there is an immediate call out directly into the MDU. And the MDU is that mobile dispatch unit or centralized dispatch unit that FPH will have that will hopefully coordinate all efforts between the mobile crisis, the children, youth, and mobile crisis teams and mobile rapid response teams, and the DCRs. So kind of a catch-all for everything, which currently is dispatched out separately, but this will be more of a streamlined process.
Okay, awesome. Thank you.
And we will ensure that information is put out there. Right now, we're not publicizing it because we want these teams up and running before the information. Now, there is a line and it is being used by community members. The front door should always be 988 for any of those experiencing a behavioral health crisis. They get an immediate behavioral health responder who can address that. So we want to be clear on that. If, when in doubt, 988 is the best number. Either one will get there. 988 just takes a little bit longer.
Wonderful. Any other questions about the endorsed mobile crisis team specifically? Hearing none, next we wanted to provide an update on some new facilities that would be coming into our region. The first is Multi-Care Deaconess Hospital has received a Commerce grant and is planning to open an inpatient psychiatric hospital within their Deaconess South location that will provide voluntary and involuntary services. This facility is planned to open either late 2026 or early 2027. So we're excited about another facility coming on board. And then in addition to that, the Man Grandstaff VA Medical Center has been exploring the possibility of accepting involuntary veterans into their inpatient psychiatric unit. And some background on that, currently the VA in Puget Sound is the only VA that accepts veterans on an involuntary basis. But our local VA is looking into potentially accepting involuntary veterans as well. We have no anticipated date for that at this time, but we just wanted to let you know that that is something that they are considering and is potentially in the works that could help the veterans in our region. Any
That's
questions on
fantastic.
that one? Yeah, we're very excited about that, and more to come once we learn more about that as well.
Just a comment on the VA for just a second. My goal here is not to be critical, but just a comment related to this. I just know that it's for veterans here, it's Sacred Heart. It's basically impossible for us to get someone to the VA, even if they are voluntary, because pretty much going from an emergency department to an urgent care, which is their requirement, is like an EMTALA violation. Second to that, they only want to do a direct inpatient psych to inpatient psych transfer. And it's kind of like, once we get a patient inpatient, the facility is not going to want to turn around and transfer them to another facility. So again, not to be critical, but it'd be fantastic if they could take in all patients, but it would also be really nice if the VA could sort of make the process of voluntary placement a whole lot easier as well.
Yeah, that makes a lot of sense.
Yeah, we're working on that. Part of the conversation we had with the VA was to express if they're wanting to go down this route and maintain a psychiatric unit, why can't we utilize it with the existing capacity for voluntary? And they have acknowledged that there is a unique aspect to how they run an internal unit, which may or may not be the same level of involvement that other dedicated psychiatric inpatient units do that in the community. And so we've used that opportunity. As you and I both know, though, the VA is federal and they pretty much do what they want on that one. In fact, we're a little bit interested to see how they're going to do this ITA portion as well, because technically state law doesn't apply in the case of individuals served there. The one thing they did indicate, and very clearly, is they have sole jurisdiction on who they will accept. So that will continue to be an issue for medical clearance. And so it may not be an immediate thing that's resolved because they do have some limitations on the medical complications they're willing to accept, but they are hoping to beef up their response on the unit. The second thing is they also have to take the potential overflow from Seattle. Part of the agreement was transition from other VAs. So they may need to ensure if that's the case. There may not be an immediate availability of beds that you would see come online if they're serving other VA members from other areas. However, what we do know is more VA members come from Spokane to Seattle than the other way. So I know I always add in an extra 3-hour answer to everything, but in this case, we did push and use the opportunity to identify the clear need for that service for veterans in our community.
I'm so glad to hear this. Like, I am often involved with veterans who need psychiatric care inpatient, and it is impossible. Impossible.
The number one thing, though, is a veteran has to request it. That's a challenge. Some veterans don't identify it. Well, when you're currently going through a psychiatric episode, first thing in your mind is not to have a really comprehensive response to individuals. Oh yeah, my name is this and I really want to go here. So that's one thing. The second thing is history and experience. We're going to try to review that, but when you're trying to get them cleared, you're going to send them. So to Kim's point, the hospital may end up seeing more and getting clearance over than you would see a direct community. We're trying to say we can do direct community referrals instead of having to go through medical clearance. At least that's our hope.
I agree with that. They don't call me unless they were denied because of their request for VA. So in a very small population, probably.
But definitely important to note. Any other questions about the new facilities that we're hoping to have on board here in the future? Not hearing any, I will move on to an update on House Bill 1813, which is related to managed care organizations delegating crisis stabilization services to the BHASO. With that, there is a requirement that is by January 1 of 2026, BHASOs in consultation with our managed care organization partners shall develop and implement electronic care coordination data sharing standards that are consistent across regional service areas. And we as the ASO within our region have been engaging within that process and have been in discussions with HCA and the managed care organizations. We've had several meetings to prepare for this second stage, and just wanted to provide an update that is one of the ongoing efforts related to 1813 that we're currently working on. And then, so lastly, in terms of crisis system updates, the Healthcare Authority is working to develop a tool that will be used to assist triaging behavioral health crisis response services across the state, called the Acuity Guide. And we are working with our providers to get feedback as this is developed to ensure that this tool is also helpful for our region and our specific needs as it relates to the unique service area that we have, including rural counties in our urban area as well. So ongoing efforts on that acuity guide, and we are working closely with HCA to make sure that we have a good guide that is responsive to our region as well. Any questions on those last two crisis system updates, 1813 and the acuity guide that is in the works?
Thank you very much for those updates.
Wonderful. I will pass it back to you, Kim.
Thank you. Thank you. Justin, go ahead with opioid settlement.
Thank you, Kim. So as always, we have a lot of stuff going on, and then we're on an actual phase 3 of our opioid project. So I don't want to go into exhaustive detail going all the way back. Many of you listened to me do that already, and it's exhaustive. So if you would like to learn more about what we've done in the past, you can reach out to us. We can send you the link, or you can go to our county link. We actually have all of those opioid projects listed, as well as the current budget that the board has approved. That will be listed on there, and as well as the other municipalities as part of our opioid abatement council. So most of those are on there. And then the county is actually going to be developing a whole page dedicated to the work we're doing in the Crisis Relief and Sobering Center. For those have heard me talk about that ad nauseum, that too is an ongoing project for an inpatient facility, a 23-hour crisis relief and sobering center attached to the stabilization center. That will be one facility with one intake for walk-ins, law enforcement referral, community referrals. So it will be a no wrong door approach, allowing individuals to receive treatment. They'll receive immediate care, and then if they meet criteria for a higher level of care, they'll be referred over into the inpatient stabilization, withdrawal management, and the co-occurring residential. It'll be one unit. The board approved up to $5 million for the initial work on that project with opiate dollars as part of the board's original 7.2 allotment. Since that phase 1, the board has approved an additional $2 million out to different projects, including the supportive and collaborative partnership with Commerce to purchase a building for a long-term withdrawal management facility through partnership with STARS, Spokane Treatment and Recovery Services. This would allow for the county and as well as Commerce to ensure a 10-year investment by the organization to provide services, as well as allow the county to provide support, technical assistance as they work to develop to the new ASAM standards circa 2028 that is expected to go into place. So something that we're working really diligently with STARS to develop, and because they have that new facility, there is a cost savings because they're no longer having to rent, which the money can then go back into ensuring the facility is up to date and providing the service. So all really cool investments for both short-term immediate service and long-term. One of the coolest things about the new STARS program, as part of the purchase, we developed a sobering, triage, and transition program, again, mirroring what we're hoping to achieve in the long-term facility there at Crisis Relief and Sobering Center, to have an immediate walk-ins, treatment, triage, and referral to service. Since we implemented that in December of last year, meaning we actually opened, it took us 2 months to get everything cleared out, set up, and going. So it actually, contract started earlier, but facility was actually open December. We've seen over 1,000 individuals, with a current estimate of about 80% that have been referred on to higher care. And this is individuals being referred directly from the community or walking in. In fact, they've seen an increase for walk-ins. This ensures that individuals are diverted from unnecessary crisis system involvement, unnecessary involvement by law enforcement if the individual doesn't need to or has any issue requiring jail involvement or further criminal legal involvement. They can go to this facility instead, better serving the community, and also reducing unnecessary ER visits where it's simply an individual needing a safe and warm place to be able to withdraw and have support for ongoing care. That has been immensely successful, and we just recently received a joint funding partnership with the city to expand those out. So our projects with the county, I think one of the biggest wins we've seen is that we've got regional support and investment. City of Spokane Valley have been investing in the Spokane County's projects, demonstrating that we can work together and we can do so to solve problems. And I like to use that because it counters the narrative the community may see that when there is an issue and we can work together, we do so to achieve good. But it also means, and I don't want to discount this, there are still a lot of other things we need to work on. So I want to highlight that good, but still recognize there is still work. So as we look towards a long-term project for a more comprehensive investment, the board now is reviewing for phase 3 investments. This is something that we'll bring to the BHAB probably in December, if we don't end up canceling and moving to spring because of weather and or other challenges with travel. Looking at what other areas of investment the county can be making. Now, the county has invested quite a bit, almost 80% of all the funds received. A slice of that goes to administrative costs, mostly for legal involvement. That is a huge portion of it. Since it is a settlement, we have to have lawyers involved for review. And then some goes to the administrative oversight for each department that oversees it. So a lot of the county projects are done by grants and budget. They take a slice of that administrative cost as well. In fact, our department has taken the smallest slice because we've used other funds to help support that. So again, more money going out to individuals for the same level of administrative oversight. Some areas that the board has indicated may be phase 3 is additional funding to law enforcement for the sheriff's department to look at expanded upstream prevention. So that's an area that we'll want to get some input on. Expanded youth-based investments, and then doubling down on existing investments for ongoing operations at the crisis relief. We know that when when we open new facilities, some of the highest costs that are not reflected in the state funding generally, not always, but generally, is those first 6 months as services are being provided and bills are going out, but no revenue is coming in. We want to make sure that there is some startup on that. So that's another area the board is looking at. Again, this is a little teaser. I don't know what the board will be looking at, but a lot of the input from this group will go towards that. And again, that just is phase 3. We have 2 other phases with expansive money. One of phase 2, we still haven't fully actualized, and that's expanded mat treatment. Interesting story. When I went to push out our partnership and we got the city to join us for an expansion to SRHD, in the process, we realized SRHD actually had some additional revenue. So in conversation, the Board of Health said, why are we wanting to put more of the opioid dollars towards the expansion, which I heavily supported, when they already had money? And so the Board of Health actually took some of that additional revenue and pushed it towards it, relieving the need for using opioid dollars. So then now I'm sitting on the money going, well, where else do I spend this? So we're evaluating this, and we'll look at next year to see if MAP treatment expansion is still needed and how would that look. If SRHD's funding does increase that, and they are looking at expanding out times beyond the noon timeframe they had previously with the limited staff. So again, really great things, and we're finding that there's opportunities that we can capitalize on now and then use our investments wisely so we expand out existing services where we have kind of a duplicating, what do they call it? A multiplier effect on services or funding that's already in place to ensure that there's even greater increased access. So a lot of good news. Again, I highly encourage anyone to go look at what we've already done. And yes, it may not look the prettiest. We're working on our website. We'll get some pictures and other things on there, but it is informative. So that is my update. Any questions on the opioid settlement funds for this for Spokane County?
And Justin, I did share the link in the chat so everybody can utilize that to view
Excellent.
everything Justin just shared.
I had a quick question, Justin. Should have raised my
There you
hand. I apologize. Was the additional expansion dollars to hire additional staff to help manage the MAT program there at the health district?
Yeah, one of the things we identified was availability for walk-in appointments was limited, scheduled appointments. So people were waiting. So funding was used to expand staff. The hope was a one-time investment could expand staff the number of individuals that would then be enrolled in programs would generate sufficient revenue to then support the program long term. And that is what they did with the additional revenue that they received in the last year, is just put it towards that. Now, if there needs to be some funding to support the additional staffing where the additional referrals in doesn't generate enough, that's where we wanted to hold on and say, all right, let's look at it. We might need another year to get to support that expansion. What we didn't want, and this was something we learned from other regions, is if we hired like a mobile van or a separate site, it would take away from total number of resources. So we'd still be limited by staff and time availability, but also prescribers. You need a prescriber to be able to do the medication. It doesn't matter if you have a really energetic, enthusiastic behavioral health provider. I mean, they carry most of the team when you're looking at community engagement. But if they can't prescribe, then you're still limited by time frames for a prescriber. So that was another thing, is saying, what can we do to expand prescriber access while allowing external community providers to be able to make referrals in a wider frame? And I want to be clear, that was where we talked about SRHD because of existing partnerships, but other relationships with multi-care through Deaconess, we're already doing with STARS. So we've expanded out one area through partnerships where we're not directly funding as part of the opioid response, but because of our expansion allowed for greater access, this also allowed in this area. So we've already hit our goal and then some, and we're hoping to expand that further. Obviously, could we do more out there? Yes. But I do think it's not an issue now of availability of walk-in time being expanded, but adding more as we look towards 2026.
Thank you.
Yeah, thank you, Justin. Any other comments or questions? Okay, hearing none, again, feel free to jump in if they come later. Let's go ahead and move on. Tom.
I have here my I have here my CCP minutes from July and August. First, I'll do July. At this meeting, our guest was Kaylin Roy, liaison with BHASO and CCP. Brent Smith, CCP chair, facilitated the meeting. Also attending were CCP members Tom Go, Sarah Smith, Robin Segner, Sarah Leaks, Sophia Alexander, and Rose Plorty. Gail Cole had an excused absence, and Ann Simmons had resigned. To order. The June CCP meeting minutes were read and approved with one amendment. This was that the part about discussing this bylaws was omitted because it was deemed not applicable. Also, the June Behavioral Health Advisory Board meeting had already been reported on, so this was not discussed. At today's meeting, however, Kaylin did go over the CCP charter and bylaws. Sophia said the bylaws should include the idea of professional behavior of the CCP members and guests with each other. It was also mentioned that the member or guest is going to miss the meeting. They should email or call Kaylin, Brent, Robin, or Tom beforehand. We discussed the CCP budget. It was noted that the CCP needs to submit an itemized budget for the rest of the year 2025 by August. This is because in April the CCP was notified their funding had changed. It was also noted that we should prepare next year's budget 2026 by November, and that from now on we need to prepare the budget for the coming year by November of the year before. This was voted on and approved by the CCP. Brent said that it's confirmed that the CCP can use Brent's church, the Ottoman Methodist, as a place to hold the coming CCP Santa picture event. He said that we should place a sign on the church so people know which door to use, and we should pass out leaflets around the neighborhood advertising the event. It was mentioned that the CCP's election of officers will take place at the August meeting. The next CCP meeting will be held online or in person in the OBHA building on Monday, August 11, 2025 from noon to 1 p.m. Meeting was adjourned. Here are my minutes from August. At this meeting, our guests were Kaylin Roy, liaison the BHASO and CCP, and Gail Cole with Office of Behavioral Health Advocacy. Brent Smith, CCP chair, facilitated the meeting. Also attending were Robin Segner, CCP co-chair, Tom Ghost, CCP secretary, and CCP members Sarah Leaks, Sophia Alexander, and Rose Purdy. The online August 2025 CCP minutes called to order. The July 2025 CCP minutes were read and approved with one amendment. This was that all CCP officers have their name title mentioned in the CCP minutes, not just Brent Smith. We reviewed the July 2025 Behavioral Health Advisory Board meeting. At this meeting, it was mentioned that Lori Moon has resigned as a BHAB member, and that Michael Kittlestead is a new member. Michael mentioned that he has 30 years in law enforcement and is excited to be a BHAB member. There was a presentation about the Crisis Triage and Mobile Dispatch Coordination Unit, MDU, by Jan Downing and Mike Sullivan. MDU has been developed with a team that is available 24/7 for individuals who need assistance. Their primary role is triage referral. They assign the client to the next most appropriate crisis team. Clients come after contacting 988 or the crisis line. If a person requests outreaches in crisis, the client is transferred to MDU. MDU then gets a summary of what's going on, identifies where the person is at, and finds which program is more appropriate. MDU looks at if the nature of the case has to do with suicidal or homicidal ideation, or if the individual is having a psychotic episode. MDU assigns a clinician to help with the crisis. The episodes total around 787 per month. 46% of referrals go to the MCAT program. MD aligns with the 988 program and principles 988. There was a BHAB administrative update program by Ashley McGee. She said that the Spokane MDU can respond rapidly and can put people in crisis centers. They give people in crisis a place to go. They have an overdose team that can respond with Narcan. There was a crisis data dashboard update by Katie Rice. At this time, there were 345 high utilizers, 9,158 regional crisis hotline calls, 4,938 total individuals served, and 18,219 total services provided. It was mentioned that the crisis data dashboard is putting in a new system. Also, at the BHAB meeting, there was RFP, request for proposal update by Jessica Thompson. Effective May 12, 2025, there were RFPs. One request gave youth and young adult parents assistance and gave youth assistance in high school. There was an update about the behavioral health co-responder program. There's a paramedic for BH and also for medical responses. The CCB then elects officers for coming year. Officers stay the same for 2025-2026. That is Brenna's chair, Robin is co-chair, and Tom is secretary. It was mentioned that the CCP is having a table at the Evergreen Club Fun Run on August 23rd. It will need CCP applications and CCP Santa Picture event flyers for the event. The CCP bylaws were reviewed. It was mentioned the CCP should complete the budget for the following year by November of the year before, and this should be included in the bylaws. The bylaws were approved as amended. Next CCP meeting will be held online or in person at the OBHA building on Monday, September 8, 2025 from noon to 1 p.m. Meeting was adjourned. Those are my minutes from July and August.
Tom, thank you for that.
Yeah.
Any questions or comments for Tom? Thank you, appreciate it. Okay, moving on, board comments. Yeah. Kayleen, Gail, any comments just from your office? I'm seeing your head shakes no, but anything you want to say? And then same thing from Chantel for you.
Nothing pops in the mind.
I don't have anything either, thank you.
Everyone has frozen. Okay, now we're moving a little bit. Okay. So Gail and Kayleen, nothing. Chantel, any comments from NAMI?
No, thank you.
Okay, thank you so much. Public comments, any other comments for the good of the group? Okay, I'm not hearing any. So looking at next meeting, let me look here really quick. It looks like our scheduled date of Monday, the 24th is actually the Monday of Thanksgiving week. So it looks like there's kind of a question on the table about, do we want to push that out until the following Monday, which would be December 1st. Discussion on that from folks. Would that work? Is it just better to keep it as our regularly scheduled date? What do you folks think based on your schedules?
I'm okay, Kim.
Okay.
Me too.
Okay. It works for me. So let's just plan on, again, Monday, the 24th, unless county folks said it's going to be difficult for you folks based on what you have going on.
We're prepared to meet if the board is able to meet.
Sounds good. Okay, well, we will plan then on Monday, November 24th at the same time. Again, any final comments from anyone? All right, appreciate y'all being here. Thank you so much. Can I have a motion to adjourn?
Motion to adjourn.
Thank you. And a second?
Second.
Perfect. Thank you, everyone. Have a good afternoon.
Thank you.
Bye-bye.
Good evening.
Everybody.
Take care, everyone. My shooting abilities definitely hurts my ego a little bit.